Next, we'll be moving on to the last session before lunch break. So that is on sports medicine. And may I kindly invite Professor Dr. Sanjay Kumar Pandey and Dr. Prabir Mandal to chair the session. This session will be taken by Ames Kalyani, both the speakers. And I'll leave it for the chairpersons to introduce the speakers to you.
Good afternoon to chairperson, all the senior professors, dignitaries and participants present here. And thank you the organizer to giving me the opportunity for this. Today's my topic is shoulder injuries. As such, it is a very vast topic. I have divided it into starting from the basics to type of injuries. Racket sports, as per se, Hughes and Bartlett describe racket sports as a net and wall game that are score dependent, and that is not time dependent. So this kind of match can go on and go on. In history, we have seen that racket sports matches have gone more than 10 hours. Popular racket sports are tennis, badminton, squash, table tennis, racquetball, etc. It is very physical demanding game, and having the potential for both acute and chronic injuries. Shoulder joint is a complex of 3 true and 1 pseudo joint. Glenohumeral, acromioclavicular, and sternoclavicular is true joint, and scapulothoracic is a pseudo joint. Some sport-specific biomechanics of the shoulder joint. As we know that glenohumeral joint is a shallow ball and socket joint, which is less stable and more mobile. And effective shoulder function requires stability of both static and dynamic stabilizers. Static stabilizer, the main function of the static stabilizer is to position the glenohumeral head to the glenoid cavity. Glenoid labrum increases the superior inferior diameter of the glenoid by 75% and anterior to posterior diameter by 50%. In picture, I have shown the various ligaments. In these ligaments, inferior glenohumeral ligament is the main ligament, which is the main static stabilizer, which in functional positions its main action comes in the functional position. Then in dynamic stabilizers, which are the rotator cuff muscles, static stabilizers are all ligaments. Overhead athletes often exhibit stronger internal rotators with subsequently relatively weak external rotator, resulting in a lower external rotator to internal rotator ratio. This is the force couple concept of the rotator cuff, which we will see later. Role of the scapula in a normal shoulder function. Normal shoulder function requires smooth integration of movement, that is called scapulohumeral rhythm. Muscle controlling the scapula are trapezius, serratus anterior, rhomboids, levator scapulae, and pectoralis minor, which works in coordinated patterns called the force couples. Full upper limb elevation required rotation of the scapula and clavicle as couple movement, which ensured that the coracoacromial arch is removed from the path of greater tuberosity, which will lead to impingement. So our main aim is to avoid the potential impingement. Scapulohumeral rhythm enhances joint stability at greater than 90 degrees of abduction. This is the concept of the force couple controlling the scapular motions. We have said the picture A is showing internal and external rotation force couple. Picture B is showing upward and downward rotation force couple, and picture C is showing anterior and posterior tilting force couples. Internal and external rotation force couple is controlled by the serratus anterior and trapezius, and upward downward rotation force couple is controlled by the upper trapezius and serratus anterior, and anterior posterior tilting force couple is controlled by the lower trapezius and serratus anterior. Who is at risk of racket sports injuries? shoulder injuries in racket sports. The person who is having incorrect stroke technique, using the improper equipment, lack of conditioning of the muscles, inadequate warm up and cool down, playing too frequently without enough rest, and playing on the wrong surface. This is a data which have been taken from the British Journal of Sports Medicine. In this, percentage of injury have been shown in squash, tennis, and badminton, and we see that at the shoulder level, tennis and squash player have similar kind of percentage of injury at shoulder, but badminton players are having less. Causes and pathology of the shoulder joint injuries in racket sports are similar to other overhead and throwing sports. Badminton and squash players have the higher frequency of traumatic injuries, but overuse injuries are well seen in the tennis players. Biomechanics of tennis are similar to those of other racket sports. So my presentation is based on the tennis player having the overuse injuries. Shoulder is subjected to high loads during the serve in tennis, where it is abducted to 140 to 160 degree and 160 to 1 rotate at a rate of up to 2400 degree per second. During the cocking phase of the serve, supraspinatus, infraspinatus, and serratus anterior all contract concentrically to establish the scapula and stabilize the scapula and the glenohumeral joint. This is followed by rapid eccentric contraction of the rotator cuff and serratus anterior to decelerate the arm during the follow through. These repeated concentric and eccentric contraction, which occur during both serving and ground strokes, may lead to muscular fatigue and so-called eccentric failure of the tendons. To generate power during a serve, there should be coordinated activation of legs, hips, trunk, shoulder, and arm, so-called kinetic chain, to achieve a high racket speed at impact. Suboptimal kinetic chain mechanics may overload the upper limb as it will try to make up for the lost energy production, known as catch-up phenomenon. Common clues that will point to poor kinetic chain is insufficient knee bend, inadequate rotation, inadequate shoulder and pelvic tilt during the loading phase. Functional movement screen. In recent years, functional movement screen has become a tool for assessing the injury risk of athletes. Functional movement screen evaluates 7 key movements to detect individual functional abilities, movement patterns, and asymmetries, helping to identify potential injury risk. Score below 14 and are having higher risk of sports injury. Higher scoring scores higher than 14 have typically demonstrating better flexibility, balance, and strength control. Maximum score is of 21 points. Acute versus overuse shoulder pain. Athletic shoulder injuries are the result of one of the two mechanisms. Acute external force applied to the shoulder complex, which will lead to macro trauma, or repetitive overhead activity and overuse causing micro trauma. Traumatic injuries such as dislocation, subluxation, acromioclavicular joint sprains, and soft tissue injuries are less. Most injuries result from the repetitive overuse mechanism. First aid management is rest, ice, compression, elevation, and referral. How can racket sports injury be prevented? Some important tips for preventing racket sports injuries include the prevention procedures, balance training with eye open and eye closed, core stability training, coordination and agility exercises, choosing appropriate footwear, endurance and strength training, organized warm-up, taping and bracing, and using the lighter racket. Causes of shoulder pain can be as enumerated in the table. Impingement. Impingement is a cluster of symptoms that occur Rotator cuff pathology, scapular dyskinesia, shoulder instability, biceps pathology, and superior labrum slap lesion, glenohumeral internal rotation deficit, or posterior shoulder stiffness have been suggested to cause shoulder impingement symptoms. Two types of impingement, subacromial and internal. Subacromial or external. Subacromial impingement is also called external impingement. Is a mechanical encroachment of the soft tissue in the subacromial space between the humeral head and the acromial arch. Encroachment particularly takes place in the mid-range of the motion, which will lead to the painful arc during the active abduction. Internal impingement comprises encroachment of the rotator cuff tendons between the humeral head and the glenoid rim. Internal impingement particularly occurs when the humeral shaft goes beyond the plane of the body of the scapula during the cocking phase of the throwing. Under normal circumstances, the scapula goes into retraction simultaneously with the horizontal abduction movement of the humerus. Impingement also classified as primary and secondary. In primary impingement, structural narrowing of the subacromial space causes pain and dysfunction such as acromioclavicular arthropathy, type 2 or type 3 acromions, subacromial bone spurs, or swelling of the soft tissue in the subacromial arch space. The bony subacromial abnormalities result from either a congenital abnormality or osteophyte formation. In addition, the undersurface of the acromion may be abnormally beaked, curved, or hooked. In secondary impingement, there are no structural obstruction causing the encroachment, but rather functional problem occurring only in the specific position. Rotator cuff weakness, instability, and scapular dyskinesis leads to secondary impingement symptoms. Secondary impingement may occur in the subacromial space as well as internal in the glenohumeral joints. Shoulder symptoms modification procedure. This is a basic principle which will done by the clinician to define a position of movement that causes symptoms based on the clinical examination, correct the possible cause of the symptoms based on the biomechanics, observe possible changes in symptoms. Shoulder symptom modification procedure help to make a rehab plan, help identify the factor that alleviate the patient's shoulder symptoms. Rotator cuff, these are the tests which to find out the pathology. Rotator cuff tendinopathy can having the extrinsic mechanism and intrinsic mechanisms. Times are very. Rotator cuff tendon player will complain of pain with overhead sports. Active movement may be painful within the painful arc. Corticosteroid injection provides short-term pain relief but impairs long-term recovery for tendinopathies. Rotator cuff tear present with shoulder pain during activity, inability to sleep on affected shoulder, having positive impingement sign. Diagnosis is done on MRI or ultrasound. Small and partial tear thickness, we can try conservative treatment. In full thickness tear, surgery is option. Most surgical repair, however, athletic performance often does not return to pre-operative levels. This is a test of the biceps and slap lesions. Bicep-related pathology and slap lesion can be of three categories: inflammatory, instability of bicep tendon in bicipital group. The labrum is a primary attachment for shoulder capsule and glenohumeral ligament. Superior aspect of the glenoid labrum also serves as the attachment for the tendon for long head of bicep. Treatment of slap lesion. Initially treated by non-operative method, unstable lateral tears or rotator cuff tears warrants earlier operative interventions. Edwards et al. Showed that 50% of the conservatively treated athletes returned to play with similar return to sports as those who had surgery. Result of arthroscopic repair of slap lesion in overhead athletes much less predictable, with return to previous performance levels ranging between 20 to 90%. Rehabilitation and return to play from injury to full recovery. Professional assessment should be done, and accordingly a diagnosis and rehab plan should be planned. Gradual return is a phased approach. Ensure the injury is fully healed. Strengthening exercise focus on restoring the strength and range of motion to the injured area. Re-evaluating technique. Address any underlying technical flaws that contributed to injury. Shiska and Cromwell showed that participation in stretching does not reduce the risk of overuse injury, but does reduce the risk of muscle strain injury. In return to play criteria is for the overhead throwing athletes following shoulder injuries. No to little pain. We will give the questionnaires according to player. if full range of motion and side difference of glenohumeral internal rotation deficit is less than 20 degree and total range of motion deficit is less than 5 degree, then normal strength, dominant side 10% strength in thrower equal to strength in symmetric sports, ER by IR ratio 66%. Then we can go 75% in the handheld dynamometer if power is 75% in hand dynamometer in neutral position and 95% in handheld dynamometer in 90% abduction. Normal scapular function, slight scapular asymmetry allowed in resting position, scapular upper rotation, full elevation. And normal function ability is seated medicine, ball throw, Y balance test, endurance test, rotator cuff. Key takeaways is reiterate that injuries are a common part of the racket sport but can be managed and prevented. Summarize the importance of good technique, proper conditioning and listening to your body. Emphasize that the right knowledge and habits can keep players on the court longer and injury free.
Thank you for your talk. Thanks. Okay, we would like to invite our next speaker, Dr. Mayanak Rai, doing senior residency in the Department of Orthopedics at All India Institute of Medical Sciences, Kalyani. Dr. Mayanak, over to you.
Hello, good afternoon everyone. First I want to begin by thanking Kaustav sir and all the organizers for having me here and giving me this opportunity. Today I will be focusing mainly on surgical management of shoulder injuries in racket sports. Though the presentation will mainly highlight on preoperative patient evaluation, preoperative investigation and the consequent surgical techniques. As we all know, shoulder sports injuries are high prevalence due to repeated overhead motion. Serve and overhead strokes generate extreme rotational forces. It is usually the chronic microtrauma that are more important than acute injury in most athletes. And most common pathologies include rotator cuff tears, slap lesion, biceps disorders, and shoulder dislocation. And I will be focusing on mainly on these 4 topics. Symptoms include shoulder pain, reduced power, loss of control. And our goal is to restore the function while preserving motion, essential for overhead sports. So the biomechanics and injury mechanisms for rotator cuff tears include repeated external and internal rotation cycles create shear forces, internal impingement, which is contact between greater tuberosity and the posterior superior labrum, and there is an entity called GIRD, which is glenohumeral internal rotation deficit. The posterior capsule tightens and adaptive changes from repetitive external rotation during serving in racket sports leads to altered humeral head translation, which increases the shear forces further. As we all know, and it has been already highlighted, the imaging for surgical planning, MRI, it is the gold standard. It helps us to assess the tear thickness, partial versus full, location. It also identifies labral and biceps tendon pathology. High resolution 3 Tesla MRI provides detection of even undersurface tears. There's another investigation called MR arthrogram. It is a contrast enhanced MRI. Mainly the abduction external rotation views are particularly useful for internal impingement, best for throwers and high demand overhead athletes. USG, as we all know, is an inexpensive tool, real-time dynamic tool. It is very effective for identifying full thickness tears. However, it is operator dependent and limited evaluation of deep and intratendinous lesions. So coming to the main types of rotator cuff tear in racket sports, the first are the so-called pasta lesions, which include the partial articular sided tendon avulsion. It is the most common pattern in tennis or badminton players. It is caused by internal impingement during extreme abduction and external rotation. Next comes the paint lesion or the partial articular sided intratendinous tear. It is a kind of partial thickness tear within the tendon layers. The upper surface remains intact. It is mainly seen in high demand overhead athletes. Next comes the bursal-sided partial thickness tears. It is less common and often seen with subacromial bursitis. After that comes the full thickness rotator cuff tear. It occurs mainly in older players due to degenerative changes, and it is associated with weakness and functional decline. Treatment options for all the major categories of rotator cuff tears include: for PASTA, first line is obviously non-operative, rest, rehabilitation, physiotherapy. If it doesn't resolve, then we go for arthroscopic debridement for less than 50% tendon involvement. If it doesn't resolve, then we go for complete repair. For pain, it is similar, non-operative rehab first, followed by arthroscopic side-to-side repair, followed by addressing the internal impingement sources like capsular tightness. For bursal-sided also, physiotherapy first, arthroscopic debridement if it is less than 50%, conversion to full thickness tear plus repair for more than 50% bursal involvement. For full thickness tears, non-operative trial is given in low demand or older athletes. Then we go for arthroscopic repair with suture anchor. If it fails, then we go for open repair. There are some studies highlighting biologic augmentation like use of patch or PRP in large or degenerative tears. Next, coming to the slap tears in racket athletes, it is by definition superior labrum, antero-posterior tear. Common mechanism is the peel back phenomena during extreme abduction, external rotation, as happens during severe serve or smash. Symptoms include pain, clicking, reduced power, loss of control. Imaging clues: abduction, external rotation view on MR arthrogram. Conservative methods: if fails, then surgery is indicated. Surgical options include slap repair in young elite athletes. So as we can all see, this is the normal biceps tendon, and this is the, here are the superior labrum tears. Next, coming to the biceps tendon pathology, it is very common in overhead racket sports due to traction and torsional forces. Symptoms are same: anterior shoulder pain, clicking, reduced power. Imaging: tendon thickening, fluid in groove, dynamic USG for subluxation. Initial treatment is rest, NSAID, physiotherapy. If it fails, we go for surgical option. Biceps stenodesis is the preferred method. It maintains strength and performance. This is the classic Popeye eye sign in long head of biceps tear, where a bulge can be appreciated in the distal part of the arm in full thickness long head biceps tear. Now, what is biceps stenodesis? It is a surgical procedure where the long head of biceps is detached from its origin, and from its superior labral origin, the tendon is then refixed to the humerus, usually in the bicipital groove or slightly below it. It removes pain from the diseased or unstable intra-articular portion. It preserves the bicep strength and prevents cosmetic deformity. So it is mainly preferred in athletes because it maintains shoulder function and power. Next, coming to shoulder instability, it is caused by repeated overhead motion leading to micro stretching of the capsule, or due to violent trauma leading to acute dislocation. High risk movements: serve, smash, overhead throws. Patterns include mainly anterior and posterior instability. Shoulder instability, first symptoms include severe pain, loss of shoulder contour in acute dislocation. Imaging: same X-ray, CT to determine amount of glenoid bone loss. MRI helps in soft tissue identifying the soft tissue lesions. Initial treatment is closed or open reduction plus immobilization plus rehabilitation. If it fails, then surgical options are explored. So coming to the next one, traumatic anterior instability, it is the commonest type. Recurrent dislocation may lead to the classical Bankart lesion and the Hill-Sachs lesion. Recurrent subluxation alternate with dislocation. Patient age more than 50 years often associated with tears of rotator cuff. In X-ray, we find the empty glenoid sign in anterior shoulder dislocation mainly. So coming to the Bankart lesion, it is basically stripping of the glenoid labrum and periosteum from the anterior-inferior surface of the glenoid. This is the normal one, and this is the glenoid labrum that is stripped. This is known as the Bankart lesion. Next, coming to the Hill-Sachs lesion, it is actually a bony defect created on the posterolateral quadrant caused by impingement of the anterior edge of the glenoid on the humeral head as it dislocates. The clinical examination mainly are apprehension, relocation, and anterior draw test. In apprehension test, in abduction, external rotation, patient has the feeling of shoulder coming out it will be appreciated from his facial expression, or he will tell to stop the test. Relocation, in relocation we apply a backward directed force. In abduction external rotation, the apprehension of the patient eases since the head is relocated in the cavity. In anterior draw test, there is increased anterior translation when the scapula is fixed and anterior force is applied to the humeral head. Surgical treatment are of various types, but mainly these two types are used. Anatomical repair is the Bankart repair. Arthroscopically, the anterior part of the labrum that is detached is fixed to the bone. It restores normal anatomy. Ideal when the bone loss is less than 20 to 25%, commonly performed in young athletes. The next comes the non-anatomical repair, the lateral or Bristow procedure. It is transfer of coracoid bone block to restore the anterior stability. It provides two types of function. It has one, the bony augmentation increases the jump distance, plus the conjoint tendon has a sling effect which further prevents dislocation. It is excellent for high demand or contact athletes. It is indicated in significant glenoid bone loss, more than 20 to 25%, engaging Hill-Sachs and failed Bankart repair. So this is the Bankart repair technique in which suture anchors are used to suture the stripped off glenoid labrum to the bone. And this is the arthroscopic Bankart repair patient position, where the patient is kept in lateral decubitus position and weights are attached and hang to distract the joint so that scope can be inserted. This is the lateral Bristow procedure in which the coracoid is cut and it is fixed to the anterior glenoid surface. It increases the jump distance as well as the sling effect of the anterior conjoint tendon prevents further dislocation. Last, coming to the posterior instability, it is caused by repeated forward flexion plus internal rotation. Symptoms include deep posterior pain, clicking, reduced power. Acute posterior dislocation is actually rare. It is caused by fall on outstretched arm or sudden forced internal rotation. It is frequently missed on X-ray. The classical sign is the light bulb appearance or the globular humeral head look on X-ray. May produce reverse Hill-Sachs lesion managed with urgent reduction. Surgery if instability persists. Posterior drawer test, it is more posterior translation when scapula is fixed, and jerk test when axial pressure is applied with hand kept in abduction internal rotation, a jerk or click is felt. And treatment of posterior shoulder instability, initial obviously physiotherapy, rehabilitation is the first line. If it fails, then we go for surgery. Indications include persistent symptoms after 4 to 6 months of structured rehab. Instability continues to affect sport performance. No acute dislocation or fracture requiring alternate method of treatment. Athlete is motivated, compliant and understands expectation. MRI shows posterior labral tear or capsular redundancy. Surgical procedures performed: arthroscopic repair of posterior labrum to posterior glenoid, tightening of posterior capsule. This is the reverse Bankart tear seen on the posterior aspect. Concluding, shoulder injuries in racket sports mainly result from repeated overhead stress or faulty biomechanics. Rehabilitation obviously remains the first line, focusing on motion, strength and kinetic chain control. Surgery is reserved for persistent symptoms or structural lesions affecting performance. Thank you.
Thank you, both the speakers.
Thank you, sir.
And now we are going to conclude the session. One question.
Yes, sir.
Thank you very much for your very nice presentation.
Thank you,
Simple
sir.
question.
Yes, sir.
I am asking you. After the repair of, you see, repeated, that is chronic shoulder dislocation, from postoperative day, from which date you will start the therapeutic exercises?
Sir, the pendulum exercises, elbow ROM, wrist ROM, these are started from next day itself. Only we advise on not doing overhead abduction, external rotation, because the suture anchors that are placed may come off. And then slowly after 2 weeks, when the start ROM exercises.
Thank you. If any questions, we can ask at lunch session. Thank you.
Thank you so much, speakers, for this shoulder injury presentation, because now winter is coming, lot of our patients would be playing badminton and they would be prone to injuries, so we'll be in a better state for managing them.